Tēnā koutou katoa. It is my pleasure to introduce Paul Huggan. Paul is an infectious disease and acute medicine physician originating from Scotland, best place in the world next to New Zealand. He chairs both Waikato DHB Sepsis Action Group and the newly formed New Zealand Sepsis Trust. He received the Clyde Wade Award last year in recognition of his willingness to share his knowledge and teach others, which is rather fitting where tonight Paul will be sharing his knowledge around sepsis and how to improve early recognition, screening and increase chances of survival. At present, mortality from sepsis exceeds that of heart disease and stroke, hence early recognition is crucial.
Well, thank you very much for the introduction, Catherine, and welcome everybody from around the country to spend an hour with us discussing a topic which I probably spend rather too much time studying, but which I believe is nationally important. And this is my first time participating as a speaker on a webinar, so those of you that can do so, please be patient if there's any technical difficulties. I'm very happy to take questions as we go along, but they'll have to be moderated through Catherine because I'm concentrating very hard on keeping a straight face and keeping the presentation going. So before I switch to my slides and do the technical wizardry involved in doing that, I just thought I'd sketch out a little bit about my background. So I am an infectious disease physician by training. I do general and acute medicine. I think that it's important to understand that what got me interested in sepsis was that I was doing all of that work in my general acute medicine time. Infectious diseases is not a specialty that you choose if you want to learn about sepsis. It's a disease that's very much a frontline emergency medicine, general practice, general medicine, and intensive care unit condition for reasons which we'll probably explore during this presentation. And that's where I'm seeing patients have bad outcomes, and that's where I'm seeing problems in the system, which I think by and large could be easily remedied if we took sepsis seriously. We'll be talking tonight about a case that we've dealt with recently, which had a mixture of good and bad outcomes associated with it. I'll be inviting comments from participants as to why those outcomes occurred and where they might have been improved. I'll be talking a little bit about what sepsis actually is and how to talk about it with your colleagues and with your patients, which we found is actually quite a difficult challenge to meet and something we don't talk about as often as we should amongst ourselves. And I'd like to talk a little bit towards the end of this about how the tools that we've developed together with the UK Sepsis Trust might make it easier for you to recognise and manage a case of sepsis if you come across one, and you're likely to, because sepsis is common. And then I'd like to, if I can, talk, if we have time, talk to you a little bit about what we're doing at a national level to try and make sure that sepsis is well taken care of now and into the future. So at this point, I have to make sure that I've actually showing you my slides. Fantastic. So, like I said, I'm from the beautiful rolling green verdant hills of southern Scotland, which has got lots of lovely university towns with wide rivers and beautiful bridges. And I've managed to move to a beautiful verdant part of the countryside with beautiful hills, wide rivers, universities and beautiful bridges. So not much has changed in my life overall, although I have travelled around a wee bit in my time. And here's the outline of the talk that I gave you earlier on. So let's just go straight on and talk a little bit about where I work and the person that whose story I want to share with you today. So I work in Hamilton, which is in the middle of the Waikato District Health Board. It takes about 7 hours to drive from Colville in the north to the National Park in the south. There's about 440,000 people living here, 20% of whom are Maori, and 60% of whom live more than an hour's drive from the main tertiary hospital. We recognise problems with providing people timely access to healthcare across the region, and that includes out of hours in primary care environments and also in the four rural hospitals that we run in Thames, Tokoroa, Te Kuiti, Te Awamutu and Taumaranui. And those of you who are sharp will notice that that's actually 5 regional hospitals plus the Waikato Hospital, which is in Hamilton. So this is Rangi's story. Rangi comes from Te Kuiti, which is 50 kilometres south of Hamilton. And you probably recognised Rangi from your practice. He's 66 years old. He's independently living with needing a little bit of help with gardening and shopping, probably because he's a bit overweight. He's recently been diagnosed with diabetes, having had a heart attack 5 years ago. He's on treatment for hypertension and has mild renal impairment. There's really nothing out of the ordinary about that story, as many of you who manage chronic disease will know. He attends his GP complaining one day of a sore, swollen right leg. There's no problem with his consultation at all. It's appropriately recognised as being a skin and soft tissue infection. He's given what would be at the low end of the normal range of an antibiotic called cefalexin, given 500 milligrams 3 times a day. And by and large, his vital signs are normal, although his respiratory rate's not counted. 2 days later, he is seriously unwell. And actually, he was brought to Acute Hospital because his family were concerned, and Rangi had probably lost the ability to take care of himself by the time he actually arrived in the GP-run hospital in Acute. He was complaining of shortness of breath. He was rigorous. He was feverish, and he felt like he was going to die. He felt as bad as he had ever felt in his life. As I said, his family had taken him to the local hospital where he was admitted at 5 o'clock in the evening. His right leg was swollen. It was documented that the cellulitis was spreading, and his observations were not normal now. His heart rate was 100, his blood pressure was 100/45, respiratory rate climbing, saturations dropping, which in the context of sepsis is quite a significant concern. For those of you who are using the National Early Warning Score, this gave him a composite score of 7, which indicates somebody with serious physiologic derangement. He was given an intravenous dose of flucloxacillin, some oxygen, and was put in the back of an ambulance without a fluid bolus. On arrival in the emergency department, and you'll note this is now 11 o'clock after all the transport time, his observations are still not getting any better. His blood pressure is almost 50 millimeters of mercury lower than his normal blood pressure. His respiratory rate's climbing, he's more febrile, he's needing quite a high flow oxygen to maintain normal saturations, and he's rightly moved to the resus area in the emergency department, where he has antibiotics before he receives blood cultures, which is sort of a sequencing error. He's somewhat better with fluids and analgesia, so he's moved to a ward. The doctor who sees him in the ward realises he isn't well at all and moves him to the HDU, whereupon a catheter is placed to measure his urine output. He's not producing any urine. He's moved to ICU. Now it's 12 hours after he presented to hospital in Acute with what could have been determined at the time to be a critical illness. And this is not an admission that went well. So Rangi stayed in ICU for 5 days. He had a lung injury. He had multiple invasive lines to maintain noradrenaline infusions. He received dialysis over the first couple of days of his stay. He needed a lot of analgesia, and this contributed to delirium. He underwent anesthesia for multiple debridements of his leg. And the trick here was that this wasn't a standard cellulitis. This was a staphylococcal abscess. And actually, there was a mixed growth of Staph aureus and E. coli in his leg. So this was an unusual soft tissue infection, and which had probably occurred because, which he was probably predisposed to because of his obesity and diabetes. So, I mean, from a statistical point of view, this might be a good outcome. So Rangi survives a hospital admission, but with ongoing pain, poor renal recovery, the need for further plastic surgery, clinic visits and procedures. He spent 9 days in Waikato Hospital, 26 days in the community hospital in Acute, and he's now at home, but far more frail. And my reflections on this case are as follows, and I guess the questions we've asked ourselves are as follows. Did Rangi have a clear understanding of what to do if his symptoms worsened when he was discharged from his first GP visit? Did we recognise the risk that he was at of deterioration when he was first assessed, and use critical language to communicate this to other members of the acute healthcare chain? Did people do the right things in the right order? And was this a typical outcome? So I think the answer to a number of these questions is no. And the answer to the last question is actually yes. In a setting where we do not take a disease seriously enough to have a single protocol about how to handle it, and take the time to make sure that all of the healthcare providers in the healthcare system know exactly what to do when they're faced with this problem, I think we're going to get variation in outcomes, and we will see this outcome more often than not in people who have sepsis. But why is this such a difficult problem in the first place? So what I'd like to invite is the comparison between sepsis and the conditions it's usually compared to: myocardial infarction and stroke. Now, myocardial infarction and stroke have had a great deal of attention paid to them. If you sit back and think for a minute, you'll realize that you have been taught about myocardial infarction and stroke, probably by a cardiologist or a neurologist or a member of staff from the Heart Foundation or the Stroke Foundation. You'll realize that you have lots of posters in your practices about heart attack and stroke, and you'll be aware that there have been multi-year investments in improving door-to-needle times for myocardial infarction, and more recently, door-to-needle times for stroke. Myocardial infarction and stroke. Myocardial infarction, if you survive to hospital admission, is probably going to cost you your life 1 in 20 times. Sepsis will cost you your life about 1 in 5 times, particularly if you're admitted to the intensive care. Stroke and myocardial infarction are not the same as sepsis. The symptoms of myocardial infarction and stroke are maximal at the point at disease onset. They have a classic clinical phenotype. In the case of myocardial infarction, people clutch their chest. They look grey and sweaty. They complain of pain going down their arms. Their blood pressure drops, and they have a classic findings on a confirmatory point of care test. The point of care test in stroke is clinical examination. An appropriate presentation and a confirmatory clinical examination will justify thrombolysis after a CT scan in our hospital. Both of these conditions lend themselves to rapid protocol-driven care. So sepsis does not fit that bill. The symptoms of sepsis are not maximal at onset. There are some classic clinical phenotypes, but there are many underlying infections which can cause a sepsis presentation. And the symptoms and signs of sepsis at onset are often the symptoms and signs of the originating infection, which means there's a great deal of heterogeneity in the way that sepsis presents. There is no confirmatory point of care test, although we do use lactate testing to document tissue hypoperfusion. That does not mean that everybody who has sepsis confirmed has a positive lactate test. So for all of these reasons, sepsis has traditionally been a difficult, slippery condition to deal with, which hasn't been owned by any one profession. So in our hospital, about half of patients with sepsis go to a medical department, and the other half go to a variety of other places in the hospital within the first 24 hours of admission, including the intensive care and high dependency units under mixture of orthopedic and surgical and other surgical departments. So no one specialty owns sepsis. It's not an infectious diseases problem. It's a whole of system problem. But how is it even defined? So sepsis arises when the body's response to an infection injures its own tissues and organs. It can lead to shock, multi-organ failure, and death, especially if not recognized and treated promptly. If you think about sepsis in 3 stages, you can start to understand how infection leads to multi-organ failure. In the first stage, a local infection overcomes the body's local defense mechanisms. Pathogenic bacteria and the toxins they express and secrete incite local inflammation and also enter the bloodstream, which leads to systemic inflammation and an increasingly complex and self-perpetuating systemic inflammatory response. This leads to clinical evidence of individual organ damage, which accumulates over time. So you may notice that somebody has breathlessness, as in Rangi's case, prostration, as in Rangi's case, reduced urine output as blood flow to the kidneys drops, and so on. In the later stages of sepsis, you develop a state of multi-organ and circulatory failure, tissue hypoxia that leads almost universally to death or prolonged intensive care admission if left untreated. What I've drawn here is maybe the key problem in all of this, which is that at the beginning of the condition, it's easy to treat, but difficult to diagnose. As things progress, it becomes easy to diagnose, but much less easy to treat. And so as I'm talking to colleagues who work in primary care and in rural hospital environments, it's very important to me to impress upon you the need to recognize sepsis at the earliest possible stage. So we'll come to how to do that in a minute, but I think that one of the topics I said I'd like to cover is how to talk about sepsis. So the other problem that we've had in the sepsis world is we keep changing the definition of sepsis. And because there's so many different things happening with sepsis, there's no single definition that's easily memorable. So we talk about professional and lay narratives. So a professional narrative for sepsis would go like this. Sepsis is characterized by life-threatening organ dysfunction due to a dysregulated host response to infection. If you try and memorize that and talk to somebody about sepsis at a dinner party using that language, you're finished. You won't be invited back, and nobody will understand what you mean. People have recognized that this is a problem, and there's something called the Marinoff definition, which is a so-called lay narrative, which is a bit easier. Sepsis is a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. Again, you're not going to make many new friends at dinner with even that. And so in my practice, I've started to look back at historic terms for sepsis, which people in the community actually have heard before. So I call these resonant terms. And when I've been speaking to patients, they'll often recognize terms septicemia and blood poisoning. And typically because they've had somebody in the family who had blood poisoning at some point in the past. The nice thing about blood poisoning due to infection as a catch-all definition of sepsis, when you're speaking in a conversational way to your patients, is that blood poisoning due to infection captures the urgency and the severity of the situation. The language actually translates the severity of the condition in a way that people can understand. The nice thing about blood poisoning due to infection is that it has a relatively direct translation into the Omari to totopiro. I understand that matipiro is a rotting illness and describes school sores. Totopiro simply means blood rot. And that's a quite evocative way to talk about a condition. And I use that a lot in my practice. So just ask, could this be sepsis? So I'd like to really impress upon you that sepsis is not a mild illness. The term sepsis has been used to describe people who are quite unwell with infection, but a lot of people who we refer to as having sepsis would probably not qualify as having sepsis if you apply the strict organ failure definitions. People who have sepsis are seriously unwell, and as in Rangi's case, recognize this themselves. They are often confused, and their relatives recognize them to be confused and acutely unwell and acutely unable to look after themselves. They complain of extreme shivering or muscle pain. They stop passing urine. They feel breathless, often without clinical signs to corroborate that symptom. They feel like they're going to die. And often, particularly in children, the skin is mottled, discolored, and cold as hypoperfusion affects the peripheries. So if you think that you have somebody in front of you who has sepsis, how do you manage the situation? Well, the good news is that there are now some tools available to help you. Because I'm predominantly talking to people who work in a practice nursing or a primary care environment, I'm going to point you first to the Breast Practice Advisory Centre guidelines, which were released this year. Okay, so I'm starting to work my way through what you would regard as your benchmark guideline for managing sepsis in primary care. Now, I can't ask you all to put your hands up. 90 people were registered for this session. I'm really pleased that you're here, but I'd be surprised if more than a handful wanted to work their way through 41 pages of guidance. You feel free, but this is actually quite a complex document and one that's hard to work through. So please do refer back to this as the benchmark guideline. All of the detail is in there if you want it. I'm going to take you instead through to the clinical tool that we've developed based on the BPAC guideline. Okay, so if you go to our website, so sepsis.org.nz, and you can all do this on your home laptops or hand phones, you come to the Sepsis Trust New Zealand website, and that's Paige, the nurse in our emergency department who got pneumonia and spent 3 days in intensive care. We've got lots of information here about sepsis and what you can do to raise funds, and lots of news about what we're doing to try and raise the profile of sepsis nationally. He says plugging his own organisation. Under clinical tools, though, you can find these three windows here. Now, at the moment, these are designed for acute care and in-hospital environments, so they're not a perfect fit to primary care, but we're developing separate tools for primary care, which will be published on this website within the next month or two. I'm going to talk you through what the tool actually looks like and why it's designed in this way. Okay. So, as I said before, Rangi was prostrated, he was confused, he had acute functional decline, he was short of breath, hypoxemic, hypotensive, tachycardic, and breathing very fast. So he clearly looked unwell. So let's have a look at how this tool would have applied to Rangi. So it's clearly important not to escalate care if people are not eligible for aggressive therapies. So if you have somebody who is, let's say, for example, in the last days of life, care plan, it would be perfectly reasonable not to escalate care. And at every stage of development, we have tried to make sure that people have latitude to make good clinical decisions. So, assuming somebody is eligible for resuscitation, are they sick? So remember, patients with sepsis look sick. If you're using the early warning score, you can start to wonder about sepsis at the point where people have an early warning score of 3 or above. And I just want to address the question, why so low? So most mandatory triggers on the early warning score occur when people are scoring about 6 or more. The reason that the early warning score is so low as a trigger for sepsis screening is that an early warning score of 4 is the lowest possible score compatible with a quick SOFA score of 1. Now, I'm using a word salad here, but what that really means is that that would meet the new official definition of sepsis, which is called sepsis 3. So there's a specific reason why the early warning score is so low to trigger sepsis screening. Assuming the person is sick enough for you to take a second look, ask yourself, could this be an infection? There are plenty diseases out there that can look like sepsis, but aren't. So a pulmonary embolism might look a bit like sepsis. You would have sepsis on your differential for somebody who is hypotensive and acutely unwell. But you have to conduct a clinical assessment, and if at the end of that you think somebody could have an infection, you can move down the left-hand side of the pathway. Now, it's the left-hand side of the pathway, which is the one we emphasize to nurses in our emergency department. If somebody has any one of these single findings, they have a red flag finding, and they need to be resuscitated immediately using what we call the sepsis 6. And I'll go over this in a bit more in a minute. Each of these, using the early warning score criteria, each of these red flags would give you an early warning score of 3 by itself. And that's what's been in use for a number of years now in the UK to trigger treatment for sepsis. And this is, in our emergency department, is a mandatory step. So if you have red flag sepsis, as we now call it, you go down straight down the left-hand side to the sepsis 6, which we'll come back to. Now, so Rangi didn't go from looking reasonably well at his first GP visit to flat out on the couch 2 days later with nothing in between. There probably was a time when Rangi was becoming more and more unwell, and there probably was a time when his relatives became concerned about his mental status and concerned about deterioration in his functional ability. And there probably was a time when his respiratory rate was climbing, and so on and so forth. So there are a number of so-called moderate risk criteria, which are not by themselves red flag criteria, but which should trigger a second thought. So if you have one or more amber flag criteria, it's reasonable then to stop and think carefully and use the resources you have available to you to make good decisions. You don't need to transfer everybody with an amber flag to hospital. Some people with sepsis can be treated in community settings, but you do need to think carefully about what you're doing with that individual. In a hospital setting, you would have access to, in most hospital settings, you would have access to venous blood gas testing. In our rural hospitals, we now have venous blood gas testing available 24 hours a day, and that's as a result of our work on sepsis. So I do understand that not every environment in New Zealand will have this available, but if you do, a lactate test is extremely useful because it justifies action and resuscitation if a lactate is greater than or equal to 2, which is a red flag finding. Let's imagine that you'd taken Rangi aside and he wasn't as unwell as all of that, and he started to look worse. Then you can start to worry more, and at some point action needs to be triggered. So if people deteriorate, by all means transfer them to hospital or ask for extra help. At the other end of this screening algorithm, we have found this box here to be very, very useful to justify not treating people as having serious infections. If you don't have red flags, if you don't have amber flags, it's unlikely that people will deteriorate and develop a full-blown septic picture. But if you do discharge people with infection on oral antibiotics, it's wise to point to resources which educate them about what sepsis looks like and feels like. And that was the missing step for Rangi. He didn't have access to safety netting advice to decide when to come back for further care. So this group tends to be low risk, but does need education. Okay. So that is what our pathways look like. I'm going to stop for a minute to ask Catherine if there are any questions that need to be answered. I'm going to try and navigate back to my slides.
Yeah, sure. We've got one from Mark. Mark is asking, is this a nationwide standard form?
Okay, that's a great question, Mark. No, this is not a nationwide standard form at the moment. We were, at the beginning of our sepsis quality improvement journey, unable to find a national form or a national guideline for sepsis. So the BPAC guideline that I showed you has only been formally endorsed and released since, I'm going to say earlier this year, middle of this year. And in the UK, the Sepsis Trust specifically developed this tool to kind of humanize the BPAC guidelines, which are a little bit too difficult to follow in practice. So no, there is no single national form, but you will not make any mistakes if you use this one, and it's free to use on your and available through the sepsis.org.nz on your smartphone.
Thank you, Paul. Kirsty's come up saying this would be interesting to show our rural hospital. So you might find it starts to move further afield after tonight. And Kate said she would love to send a copy to present to her colleagues. So yeah, you've started a ball rolling already, Paul.
Well, that's fantastic. Great to hear. And if anybody would like more information, please just do get in touch with us through our website. So if there are no other questions at this point, let's just think a little bit more about Rangi. So one of the questions I wanted to pose to you all was whether this is a typical outcome. And the answer is actually it is. So this is a survey published in 2010 by a guy called Jack Iwashina, who's a sepsis researcher in the States. And what he did was very clever. So he was able to use something called the Health in Retirement Study in the States to look at what happens before and after sepsis admissions. So everybody in the Health in Retirement Study, and there were thousands of them, was surprisingly enough in retirement, but they were having annual surveys to look at their physical and cognitive health. And what they were trying to do in that survey was define health trajectories over time that could be used to justify investments in health interventions for older people in the States. So what Jack did was he matched every sepsis admission with two controls of admissions of the same duration. And this is what he found. So if you look at the surveys of cognitive function before and after a sepsis admission, you find that the rates of moderate to severe cognitive impairment among survivors of sepsis have significantly increased compared with non-sepsis admissions. Sepsis has a specific effect on the brain, which is quite long-lived. And if you are looking after people who've had a sepsis or an intensive care admission, and just ask them, are you doing the crossword? Are you a bit slower than before? What are your relatives doing for you? You'll find that actually they're doing a lot of things that imply a brain injury. A little bit extra help with shopping, a little bit of extra help with money, a little bit of extra help just getting through every day. And that's is a significant impairment for somebody who might previously have had no cognitive impairments at all. From a functional point of view, you're 3 times more likely to have a new functional deficit after a sepsis admission, whether or not you go to intensive care. And what Jack writes about is the significant burden of survivorship. So as more people growing older with morbidities, the morbidities put you at risk, like diabetes, put you at risk of sepsis. You get a sepsis admission, and then you're more of a burden in your own life, to the people around you and to the health system. So there is a significant burden of survivorship with sepsis, which we tend to forget about because we're very concerned about mortality. Talking about mortality, we found that for any mortality that we could find in any population in our hospital at hospital discharge, mortality had doubled by 1 year. And what I mean by that is most people stay in hospital for about 20 to 28 days. If your mortality after an intensive care admission was about 20% at 28 days, you're very likely to have, you had a 40% chance of being dead at 1 year. And what's interesting about this is the number of late deaths and also the persistence in increased risk of death. So the increased risk of death amongst people who have had sepsis compared with a matched population, it persists for at least 5 years after a sepsis event. So there's something about sepsis which changes people's health trajectory. And I bet if you start looking closely at your survivors in your own practice, you'll realize they're not quite the same people that they were before they went to hospital, and they start to encounter more and more problems as time goes by. And it's a particular interest to me to see how this story plays out in the literature, because this is really relatively new data, and it's going to be interesting to see what people do with it internationally. So the last point I wanted to challenge you with was, how do you actually improve sepsis outcomes? So this quote is from the Surviving Sepsis Campaign Guidelines for 2008. Greatest outcome improvement can be made through education and process something for those caring for severe sepsis patients in the non-ICU setting and across the spectrum of acute care. So you all are part of the spectrum of acute care. So there's in any healthcare care system, you've got population health interventions, you've got the health literacy of patients, family and whānau, you've got first responders in primary care, ambulance crews, emergency departments, medical and surgical specialties. And if we're really serious about looking at sepsis, we should be auditing outcomes, conducting research, and continuous quality improvement. And that's what the spectrum of acute care looks like. And I'll make it my mission to stop just thinking about my job as being as a medical specialist in a tertiary hospital, and start working out how to help people look after infections better where they work, and where patients usually present, which is in the community and to ambulance crews. So just to provide you detail of what sepsis looks like in our audits, we have been looking at every admission to hospital with sepsis that ends up in the intensive care or high dependency unit, which is 20% of all sepsis cases. And what we've been very interested to find is that more than 10% of patients who are admitted through the ED who go to ICU have first seen their GP. Now that means they've seen the practice nurses and they've looked really sick, and they've been transferred to hospital lickety-split, and they've ended up in intensive care. So Rangi's story is not unusual, and 10% is a really conservative estimate, because we know that a number of people arrive in ambulances that have been called to GP practices. So I think a lot of people with sepsis are presenting to primary care. Why do you think the opposite? Because there's lots of GP practices. Any one individual working in general practice will probably not see a great number of sepsis cases. And it's really, really important that everybody in primary care and anybody who could see an acutely unwell patient understands what sepsis is and how to respond if they do see it. So this is the kind of material that we're starting to work on. And this is a poach from the UK Sepsis Trust, who've been incredibly generous in sharing their intellectual property and strategies with us. This looks and feels urgent. It's got a clear message on it. It's got some clinical data on it, and it makes you think about sepsis all the time. So these posters are in our emergency department and acute care areas, and really do catch your attention. We've designed a program of quality improvement, which we call the Sepsis Ready program, which is really about preparing people for sepsis, getting them to think about what they already know, helping them to navigate to the guidance that we've put on our internet page. And then at this particular version of a quality improvement program also includes audit and feedback. So what we do is, for every case of sepsis admitted to intensive care and HTU, we feed back to the people we can identify as being part of the care team as to the outcome and some of the key quality indicators which indicate timely care. So we're starting to see some early data come through. I'm really pleased to share with you that as of the 13th of September, which is patient number 38, which is that bright red vertical line, nobody has waited any more than 110 minutes to see a doctor in the emergency department, whereas before people were waiting up to 360 minutes to see a doctor. And this really indicates the power of an empowered and well-educated, motivated nursing a group of nurses in the emergency department. If you actually go down and speak to our doctors in the emergency department, they're being shown the patient with red flag sepsis and asked to assess and prescribe antibiotics. And it's those kind of direct patient care interventions which are, we hope, are going to feed through to better outcomes. So I'll remind myself to stop there. Catherine, is there anything that you want me to answer?
Well, you've started a landslide of questions now, Paul. My goodness, they've come alive. Well, not sure where to start. So here's a good one. Have rates of sepsis increased?
Wow. Okay, that is an easy and a hard question to answer. So the actual answer is probably yes and no. And it depends on how you look. So what I said at the beginning of the talk is that sepsis is everybody's problem. So if you look at heart attack, myocardial infarction, it's clear what is and what is not a myocardial infarction. And they usually go to one place. So you can usually count myocardial infarctions relatively well because they're well coded and they're easy to spot basically by counting numbers in cardiology wards. You can't do that with sepsis. You can't walk around the hospital looking for people who have got sepsis. So you have to use what's called routine data. And that comes from the International Classification of Diseases 10th version, Australasian modification, ICD-10-AN. And that's what's used to code hospital admission statistics and send them to government. And that's how we get funded, and that's how the complexity of our cases is judged, and that's how the DHBs attract money. But coding data is not felt to be very sensitive for true cases of sepsis, meaning it is only as likely to pick up 50% of all sepsis cases that present to hospital. At the same time, it's not particularly specific, which means that it's 70% specific, meaning that 30% of people who are coded as having sepsis probably don't. So it's not the methods we use to detect sepsis in hospitalized populations are not that reliable, but if you do look at them and you do look at trends, there are significant increases in sepsis incidence using ICD-10. People in the States are starting to argue that that is probably not real. That's probably a little bit of overcoding or increased recognition of sepsis where it does exist. So the shifts in trends in sepsis incidence are really hard to interpret. What's really, really important is that it's much more common than we realized before. So we estimate that about 1.5% to 2% of all patients who are admitted to our hospital, in hospitals plural in the Waikato District Health Board, are admitted with an illness compatible with sepsis. And that is a huge burden of disease because those patients stay longer in hospital than other patients. So our median length of stay is around about 7 to 9 days. And our average length of stay is more than a week. And in a hospital where the average length of stay for all medical admissions is under 2 days, that's really is a group of patients who are severely unwell. So 20% of them are admitted to intensive care, and the group that are admitted to intensive care die 40% of the time. So I think the data is useful to show there's much more than we thought there was, but as regards trends, it's harder to answer. That was a slippery, long answer to a short question. Sorry.
No, thank you. And I guess it kind of in a way links in here, but has antibiotic resistance affected outcomes?
No. Would like to point to the first line on this slide to talk about why I think that we have reasons to be concerned about antimicrobial resistance, but we need to balance that with concern with the knowledge that the vast majority of infections that present to hospital are easily treated with available antibiotics. So, as part of a national sepsis strategy, the World Health Organization recommend that you view infection control and antimicrobial stewardship and sepsis care as a trinity. That is, that they're synergistic and they interact with each other. You don't see infection control, stewardship, and sepsis care as being independent of one another. And the reasons for that is you have to carefully balance messages about antimicrobial restriction with allowing people to use antibiotics when they perceive that people really need them. And ultimately, what are you restricting, or why are you trying to save antibiotics? You're trying to save them for when you need them, and you never need them more than when somebody has got sepsis. So you have to find a way to balance this restriction versus use messages, and it's a really tricky one. We're certainly not telling everybody in the emergency department to give everybody antibiotics who looks a little bit unwell. We've never said that. What we're trying to say is give antibiotics, give the correct ones if you believe that you have good reason, if you have good reason to believe that somebody in front of you has a critical illness, and that's what sepsis is.
Thank you. And one last one before I let you move on is, this is from our friend Mark. Are people living on their own at higher risk of death?
Well, they do say that being lonely, divorced, male and middle-aged is the new smoking, if that's what you mean. If you're living on your own, well, what I will say is if you have got any of the common medical morbidities that we spend our time documenting on people's medical histories and intake forms, like atrial fibrillation, history of alcohol abuse, smoking, atrial fibrillation, heart disease, heart failure, diabetes, any one common medical morbidity increases your risk of sepsis above the part of the population that don't have any morbidity. So medical morbidity seems to be something that increases your risk of a sepsis admission. That's been well shown. I think I would, never mind being alone, the uncomfortable truth about sepsis in New Zealand is that you're 3 times more likely to be admitted with sepsis if you're Maori, if you're Pacific origins, or if you're Pacifica, or if you experience high levels of socioeconomic deprivation, regardless of ethnicity. So I'm afraid that I'm siding with the people shouting from the sidelines, saying that we have got a serious problem with inter-ethnic and inter-societal deprivation and inequality in this country, and sepsis pretty much sums that up. It's not reasonable that a male living in the Waikato in his 40s who's Maori has a 7 times increased risk of admission with sepsis compared with somebody who's non-Maori living in their 40s in the Waikato. There's very, very sharp differences in health outcomes expressed in sepsis data, and I think we need to pay close attention to that.
Thank you.
Fantastic. Okay, so just in the last minute or two, I think this is how. Well, do we need a national sepsis strategy? I would argue that we do, and this is how you might go about it. So, in 2017, the World Health Assembly, in recognition of a conservative estimate of 30 million cases of sepsis internationally and 6 million deaths every year, passed a resolution requiring member states of the World Health Organization to develop national sepsis action plans. A national sepsis, there's a fairly complicated document and there's a lot of blether, but within that, these were the themes. So that resolution encouraged member states to strengthen infection control, antimicrobial stewardship, and sepsis care initiatives in their own countries, to undertake research to determine prevalence, incidence, and cost. So there's very little information about prevalence, incidence, and cost of severe infection in any Western country, let alone New Zealand. And we certainly don't have a good idea how much money, as one indicator of outcomes, this is costing us. Presumably good sepsis care would reduce the amount you spend on sepsis, so seeing a reduction in costs is probably a good thing for patients. The second step, if you've done that in the World Health Assembly's resolution, would be to promote awareness, both public and professional, but also political awareness of sepsis. Sepsis is funded by people who realise that it's a major issue, and I don't want to be a sort of single issue healthcare professional by any means, but I am happy to speak truth to power, and that truth is that we have far more infection than we need to in this country. There are serious inequalities, and I believe something should be done about it, quote unquote. The third stage of an effective action plan would include national surveillance and reporting and research into how to include primary outcomes. And I think this would really be health outcomes research. This should be research that's focused on helping people recognise and treat sepsis better where it presents, which is to primary responders and to primary care and to people working the night shifts in our rural and regional hospitals. There, I said it. Now, let's just go back to the numbers. So I said before that we think 1.5% of all adult discharges in our hospital are for illnesses compatible with sepsis. Looking at all hospital discharges in 2015 and 2016, that would have been 12,500 cases of sepsis in New Zealand, leading to 2,500 deaths. It appears to be reasonable a target to reduce mortality by 10% amongst hospitalised patients. That would be 250 to 500 lives. And with that as a goal, I will stop and take questions.
Thank you, Paul. We've got a question here. Are there any statistics of mortality rates? You moved screens and my screen moved. Are there any statistics of mortality rates in rural hospitals compared to other hospitals?
Not to my knowledge.
There might be some research.
Yep, absolutely. Yeah, no, good comment. No, absolutely. I can say we've looked where we work at sepsis outcomes as a function of travel, distance travelled to hospital by ambulance, and there doesn't appear to be any difference in outcomes. Happily, I can say that even though you're at higher risk of presentation with sepsis if you're living in a deprived area or Maori or Pacifica, then your outcomes after you've presented in terms of mortality are the same. So there's no post-presentation difference in outcome that we've been able to detect. So this all seems to be an incidence and population health problem rather than a problem with how we take care of sepsis in hospital, although we could probably do a better job.
Thank you. Have you got any questions, Rachel?
Yeah, I just was wondering, is there any particular infections that you see more of in the hospital that become sepsis, really, so that for us in general practice, I don't know, I suppose so that we can actually recognise that might be something that someone would be more at risk of developing?
So if you have a respiratory condition or if you're a smoker, you're more likely to get pneumonia. If you've got a bladder cancer, you're more likely to get urosepsis. If you've got some kind of perforating condition in your stomach, you're more likely to get intra-abdominal sepsis. If you're Maori and if you're diabetic, you're more likely to get soft tissue infection. So I think that in part, the infections that you'll see depend on what is actually wrong with the person that you're dealing with. So there's no specific risk factors other than obviously respiratory disease leading to respiratory infections, bronchiectasis, pneumonia, and lower respiratory tract infection and so on. There are obvious risks, but actually what I would probably point out is that after the first medical assessment in the emergency department, 25% of people clearly have sepsis, but nobody knows quite why. So 1 in 4 people still have this syndromic presentation where the origin of the infection is not clear. So I think that the message for primary care and for where you might have to move somebody quickly through the system into the emergency departments and through the ambulance system is that you do not have to know where the infection is coming from. So that is the message I would leave you with. It's fine to say, I think this person has an infection. I can't put my finger on where. They're febrile, they're sick, they're shaky, their muscles are aching, they're on steroids, they're a smoker, they're Maori, they've got diabetes. I'm worried that this person has an infection. It looks like red flag sepsis. You need to see them. I can't tell you why they have got sepsis, but you need to see them. And that's part of that's part of shifting people's mindsets. You don't have to have the name of the infection to refer somebody to hospital with sepsis.
Thanks, Paul. In terms of say somebody coming into a rural practice and say antibiotic treatment or giving something IV while we're waiting for the ambulance to arrive, do you recommend anything, or do you recommend that we just leave it until you have blood gases done? Because obviously can't do those in some of the small practices?
Yeah, that's a really good question. That's a very good point, and that's just changed, hasn't it? Because the government pharmac has just allowed GP practices to hold ceftriaxone for meningococcal sepsis. So the answer about antibiotic administration probably depends on transfer time. If you have got less, I think it's the ambulance guideline talks to this. I think if your transfer time is longer than an hour, that you're supposed to get antibiotics in the ambulance. And the ambulances carry ceftriaxone, whereas they used to carry Augmentin and gentamicin. If you do have antibiotics in your practice and you've got someone that looks really unwell, no one is going to complain that you gave antibiotics. If you've got the ability to take blood cultures, even better. Take them, put them in a bag, tape them to the patient and send them to hospital. Unfortunately, there's every chance that they won't process them because hospital labs and community labs are different. But if you want to practice good care and you do have what you think are the right blood culture bottles and you could put a form together with the bottles, go for your life. I didn't get to talk about the 6 steps to sepsis resuscitation. It's relatively easy to remember, and there's good evidence that if you do all of these things, you will double people's chances of survival. So we spoke yesterday evening before this and pointed out that a lot of people attending this may be working in a hospital or acute care areas, out-of-hours practices and so forth. The key steps in sepsis care are divided into giving 3 things and taking 3 things. So the giving 3 are the most important. Give oxygen if the saturations are less than 92%. Give a reasonable bolus of fluid, so at least 500 mils through a free-flowing drip, not through a giving set. Just open up the bag and give 500 to 1,000 mils of fluid, whether or not the person's got heart failure. Just do it. And probably more importantly than everything is give the antibiotics within an hour, or as close to an hour as you can get. The take 3 is take the blood cultures if you can, take a lactate if you have access to it, and take the patient's urine output measurements if you have any concerns about their response after the first few steps. So that's called the sepsis 6. The research suggests that if you get all of those things done within the first hour, patients have about twice the chance of surviving hospitalization compared with none of those things happening.
Paul, it's been absolutely fantastic. I'm enriched with new knowledge. Ha! All armed to go back out into the battlefield, sepsis ready.
Great.
It's quite interesting you go on about the blood poisoning. I don't think it's that old school because I remember that people do. They totally connect with that one, eh? Mm-hmm. And as it's like watching that when we were practitioners for a long time, we get caught up in medical language.
Yeah. And
trying to be careful that we don't forget how the patient sits. And simple things that we think are general bread and water are not to them. So it's very important that we do actually keep going back and making sure they understand, because without the patient, the rest is not relevant anyway.
On the sepsis.org.nz, there's a sample antibiotic guideline for the first dose of antibiotics in sepsis. Feel free to have a look or use local guidelines if they're available to you.
Yeah.
How do you address patients who have red flag observations as their norm? Common sense, innovation, imagination. That's tricky. I think that would just have to not be a red flag. So if somebody's oxygen dependent with COPD, saturation is less than 92% on oxygen is a void red flag. Yeah. Sepsis in residential care. I would manage it as any other condition, really. When the primary care guidelines come online on sepsis.org.nz, it will be a little easier because there will be fewer red flag findings. It's actions recommended based on how people look. But if you've got somebody who's for resuscitation, who appears very unwell, and you're not sure what's going on and you think it could be sepsis, then if you would want resuscitation in their situation, then by all means refer and get going. There's a few tricks to that. If you're really stuck, you can give ciprofloxacin and 2 grams of flucloxacillin. You can there's all sorts of tricks that we've got up our sleeves for managing people who are maybe remote from ambulances and so forth. But if you have an acute care pathway for heart attacks in residential care, you should have an acute care pathway for sepsis. Now, there was one other question that I saw that came up about viruses versus sepsis. This came across really strongly in the pre-work that we did around the Sepsis Ready program. We had a lot of people worried that we would be giving antibiotics to everyone. It's certainly true that viruses can actually be a cause of sepsis. It's influenza, for example, frankly causes a septic illness. You don't have to have a bacterial illness to have sepsis. Our experience is that the viruses that make people ill are actually causing the mimics of sepsis. So viral bronchiolitis makes children and young adults look very breathless and very tachycardic, particularly after they've had a salbutamol nebulizer. But what we're finding is amongst the emergency department staff is that we're asking them to make the call as to whether this is sepsis or whether this is a virus, and with other findings that can be explained by that virus. So bronchiolitis is a really good example. So somebody who's having a wheezy exacerbation of asthma will probably have a red flag, but they are having a viral exacerbation of asthma. That's what the story will look like, and that's what it will sound like. And you'll be justified in watching how they do potentially without antibiotics, or if you're very worried, you can give them one dose of antibiotics and then wait to see how they do over a few hours. So that's how we've dealt with the is it viruses versus is it bacterial sepsis in our emergency department. It's not really an issue in the very sickest patients. There's a few people where there's a question mark, but by and large they're in the amber flag group, and we can stop and watch and wait for a bit. What percentage of sepsis is seen in children and young adults? Okay, I don't have great data for you. What I can tell you is that our coding algorithms to try and work that question out are not performing well. Internationally, I think it's about 10 to 15% of sepsis occurs in people under the age of 5. It may not be quite that much. I'd have to go back and check because I'm not a pediatrician. But there's a substantial number of cases of sepsis are said to happen in children. What we've realized is that our coding algorithm is not picking that up at all. So we don't have good information about kids. If you separate young and old adults into young adults being under the age of 60 and older adults being over the age of 60, that's not everyone's definition of old. Old is older than you are, I guess. But if that's your definition of old and older, then people under the age of 60 account for more than 30% of cases of sepsis in adults. So it's not the case that it's a disease of the very old. It's actually a disease that occurs in all ages. Yeah.
So I just want to thank you, Paul, for coming and talking tonight. I think that all of us that have listened to the webinar have learnt heaps from your presentation, and it's been really valuable. I know I've got a lot out of it for what we can do in general practice, and I know that all the nurses that are working in hospital areas would have got a lot out of that too. So just really want to thank you for coming and presenting tonight, and want to thank everyone that came and attended. And also Mobile Health putting on such an awesome webinar for us rural nurses that work all around New Zealand.
Great, thank you very much for the invitation to take part. Really enjoyed it.
Yeah, it was fantastic. Thank you very much.
Go on, give us one closing message. Go on, give us a plug for one of your forums you're on. Come on, give us some inspirational finish there, Paul. Go for it.
Just ask. Just ask. Could it be sepsis?
Just ask. Yeah. Cool. What sepsis looks like and feels like, eh?